Welcome to the KMA Health Front. This is a podcast by the Young Doctors Network focusing on healthcare policy, medicine, and most importantly, doctors. I am Dr. Mutonyi, convener of the Young Doctors Network.
And I am Dr. Marie-Claire Wagare, the immediate past convener of the Young Doctors Network, here with our lovely guest today, Dr. Nelly Bosire, who will be sharing some highlights on policy and advocacy. So, welcome, Daktari.
Thank you so much for having me. Yeah.
Yes, so just a snippet of Daktari's stellar bio is Daktari is an obstetrician and gynecologist. So for those of you who are thinking about doing obsgyn, this is the podcast for you to listen and tune in. She has a background in health system strengthening through health policy, advocacy, health regulation, ethics, and jurisprudence. Currently, she's a technical lead at the Championing Evidence-Based Advocacy (SEBA) project by Capricorn, focusing on advocating for increased funding in primary health care, reproductive, maternal, newborn, child, and adolescent health, and nutrition. She also has a foundation called Thriving Teens that focuses on bridging the gap towards reproductive health services for adolescents and youth. And she previously served at the Kenya Medical Practitioners and Dentists Council. And we're going to share why we've brought up that aspect later on in the podcast. So welcome, Daktari.
Thank you. Thank you very much for having me here.
Yes, I think maybe we can do a small energizer before we jump into the podcast. Yes, so if you are not going to be a doctor, what career would you have chosen? And
That's
why?
easy. I was going to be a professional dancer.
Oh, nice. You can dance fast again.
Oh, wow. I do love to dance. I do dance salsa. It's just that I don't get to have time to dance as much as I would love to. But yeah, it was something that I have loved for the last 20 years.
Amazing. So if those of you who are taking dancing classes, you now have someone to give you inspiration that your dreams are valid. You can still dance and be an amazing doctors. Yes, doctors have rhythm.
It's not always too left feet, I promise.
Yes.
So Dr. So I think you can just get right into it. I think I read your bio and I first of all, it's amazing. And
thank you.
Even my interactions with you before have just been amazing. So as a person who's gone into advocacy, I want to know what pushed you there. Was it like one moment when you were in the hospital, or was it something that you always knew you would do from the beginning, or did just opportunities just come up and you found yourself there? Like how did you get there?
Well, I think, when you're a last born, you always have to fight for your space. I was born in a family of 8. I was number 8. I'm sure sometimes when they count, they get tired along the way. I might be forgotten. And so I was always a person who always had to remind people like, hey, what's up? I'm still here. I'm still here. And then I went to high school and I never imagined that I would ever be the person who was the outstanding student. I was just happy to be in high school, living my life, being an adolescent, getting naughty, doing all the mad things. I was a serious tomboy. So I went into medical school. I thought I was going to do engineering, electrical engineering. Wow. I love to tinker with power. To date, I still do fixing sockets, but that's just fun for me, And then, unfortunately, that year, countrywide, we really didn't perform very well in physics. And that sort of hit me. So my cluster wasn't going to support me, even though I had done electricity and I was ready. And then I had to come back and start thinking, what else? So I looked at my subjects and they were just very science heavy. And then I realized I can only go to medical school. So it was medical school or nothing. And so I had to change my applications all over again. So going to medical school, I think through medicine, I remember our year in medicine was always very difficult. I'm sure they couldn't wait for us to graduate. We were always the ones who protested if the lecturers didn't come to school. We're not going to sit their exams. If they didn't meet their unit requirements, we're not going to sit that CAT. And we were just very, always outspoken, even though we were a really small class, because we only graduated 31 people. Wow. And so after that, then straight into internship. And by the time I was coming back for postgraduate in 2010, we were very restless. And this is how we formed the union. We were among the first people who started advocating for the rights of doctors. We really pushed for improved salaries. I mean, I'm proud to say that by the time the salaries came through, I was no longer working for government, so I was never a beneficiary. And the one advantage that gave me is that then I could speak out for doctors who were employed and couldn't say certain things because of fear of retribution. I wasn't employed, so I couldn't be fired. And so I could really, I sort of found myself taking up and being able to be the one who represents doctors in many conversations, pushing the union. We had just gone into devolution shortly, pushing the governors. We tried to work with them. Some of them were really cooperative, and they were seeing the bigger picture of what we're trying to say. You have to, health is a service industry, and people don't go to hospital to see CT scans. They don't go to hospital to see the fancy machine you got in the lab. They go to hospital to see the doctor. So the doctor has to be happy first. The doctor has to be in a conducive environment to deliver. The doctor has to know that you put themselves first. You cannot go home and want your nanny to feed your baby and the nanny is hungry. So, we started having those conversations. There were some really amazing governors who were listening. And we could actually see, to date, you can actually see those counties, they may be struggling with everything else. They struggle financially to be able to afford the doctors they need. But their heart is in the right place. You go to counties like Kericho, where you find that all the doctors who were medical officers for devolution have all gone to school, and now they have done their specialization. What the government is struggling with now is it's not able to sustain the budgetary allocation to be able now to hire more medical officers. So we're seeing the pyramid is turning and it's becoming top heavy. There are a lot more consultants than medical officers. And any county you see that, they started from a perspective where they put their doctor first, and they knew that if they bring them back as specialists, then they are able to actually get the service they require. Bomet is a county where every baby is seen by a pediatrician daily.
As it should.
Orthopedic surgeons actually have literally gone to the community to find anybody else who needs surgery. It's very funny. Really? The ophthalmologist there told me, we had a grant, they built for us a really lovely theater here. Now those were the days for NHIF. So they would actually have their community people go to the community, find anybody who needs care, have them enrolled in NHIF, and they would all have surgery treated at home. So and the interesting thing is that they're happy to be there. It's a remote place. They're happy to be there because they felt treated right. This is the only county that would say, now we are actually doing promotions for our doctors. Bring your papers. They didn't need people to go on strike for them to do so. So we were able to see that, look, we can actually make progress. And this is sort of what put me in the pathway inadvertently, that I would always be in the advocacy space for healthcare. And then you work with the patients, and you of course start to think about what else do they need. And really, it was never one moment, if I would say, but I think that formally the union put me on the pathway to advocacy. After that, I moved into regulation, and even at regulation, there's a heavy investment in advocating for safe care for patients, and by creating safe space for the practitioners who also practice there. So by the time I was now doing this at program level, it had been a long journey.
So you were born an advocate.
I was became a doctor. Then you became a doctor. Then you married the two.
And then you married the two.
You found
Absolutely.
That's amazing.
Yeah, and it's amazing that your journey, you noticed your journey started as early as high school. Many a times people don't realize what their strengths are from such an early age, and you kind of learn as you go with the punches. And one of the main things I think that's especially a challenge in the healthcare space is ethics in practice.
Absolutely.
I have a friend who always, whenever doctors go on strike, he defends the doctors by saying that medicine is a calling, but your landlord will not eat that calling.
That's true.
Your landlord will not eat that calling. And you find whenever doctors go on strike, there's always that card that's put that, but your doctors, the patient will be hurt. And even in medical school now, with the rise of use of social media, you wonder, we have all these influencers on social media who are giving health information, some accurate, some not accurate. And Kenya Medical Association subscribes to the International Code of Medical Ethics by the World Medical Association. but not so many doctors are aware of such documentation. So based on your experience with our regulator, which normally regulates such instances, what advice will you give to doctors in how, especially young doctors, young up-and-coming doctors, medical students, on how to progress in their practice in an ethical manner?
So I don't blame the doctors for a lot of things. Our curriculum is very heavy. It's very practical science based. We are taught the anatomy, the physiology, the biochemistry, and if you ask any medical student from year 1 to 6, their emphasis is, did I pass those key subjects and did I pass my rotations? However, we do not initiate early enough what we call the supportive environment of delivering on the science that you have. And so this is a challenge for me, because I don't think that advocacy should be a 1 or 2 people event. Advocacy is something every doctor should be taught. Because if you are not able to advocate for healthcare, then you really honestly are already handicapped, and handicapped severely. So some of these things we talk about, people look at it as it's an elite group of doctors in KMA who associate with WMA. Every single doctor in the world, subscribed or not, you are under the umbrella of the World Medical Association. We need doctors to know that. Number 2 is that you are regulated. And we all sort of come, it's very interesting that yes, I sat as a regulator at a very young age, because I had just finished my master's. In fact, I had not finished my master's when I was first sitting at the Medical Council. I was still doing my postgraduate. I didn't even know that I qualified to run. It's because I went to ask the CEO, we need to know who's running so we know who we can support, who will have the young doctors' interests at heart. And he told me, what do you mean? Why don't you run and do it from the within? And I said, what? Am I even eligible? And I found out it's just an age-related thing. When did you finish medical school? Have you practiced for at least 5 years? And you're eligible. And that is how then we used to elect our representation to the regulator. And so I was actually elected, and it was very funny because even the director, then we didn't have a director general, we had a DMS, Director Medical Services, who oversights, he was kind of like the returning officer. He actually said, I need to know this person who's voting, leading by so many votes. Because young people for the first time realized, the person who sits there and decides what's going on is actually chosen by me. And they voted for the first time. And trust me, it was a very, very analog process. Because you used to receive your voter's note in your post box as a registered mail.
God.
Oh my.
So many doctors,
post offices are going extinct.
Thank you. Now imagine, many people, the post box they put in their initial registration. Some of them, it was the local high school. So they're like, you mean my letter went where? I have to travel for it, because remember it's registered mail. You can't even pick it. You can't have someone pick for you.
Yes.
But then we went through the process of election, and I felt like we needed to do something. And one of the things I was very grateful for is that in the term that I served at the Medical Council was a time when by law, Medical Council was responsible for medical training from curriculum level. It had to partner with the Commission for University Education to approve the content. And one of the things we put forward was that we need to have a basic curriculum, like a core curriculum by KMPDC, which then all medical schools would take, look at it, and then build on it. And some of the core things we inbuilt in that curriculum, one was communication. 2 was actually research methods, and 3 was policy advocacy. We said these are things, and then 4 was regulation. Regulation was always there, but it was not strong. And we're very, very, very emphatic that they need to have enough units to force the universities to actually look at the broader picture of what is required in ethical regulation. And we understood that then if we start to infuse this information from a very low level, by the time somebody is going for internship and getting registered, they actually understand the role of the regulator in their practice. And they understand the role that professional associations play in ensuring that regulation is effectively implemented, because we are a professional society. We want to self-regulate, but for us to self-regulate, it comes with a lot of responsibility. And the first responsibility is knowledge. You cannot not know, because in this country, by law, we all know that ignorance is no defense. So at which point are we teaching doctors? Because if you go to the legal profession, literally, by the time you join medical school, you know what is Law Society of Kenya.
Yes.
You understand?
Yeah.
And for them, people think that LSK is just an association. LSK is an umbrella body that brings together what would be their union aspect, their regulator aspect, and their professional association aspect under one roof. You understand?
Yes.
So we have them standing independently, but it is really important for all of us to understand what these bodies do, because that way then we build that sort of culture that as doctors, there's something that binds us together irrespective of where you go, what you do, what your affiliations are, what kind of career path you choose. It's not a one-off. I am happy now that organizations like Emory have started having trainings that actually are certificate trainings that are geared towards ethical regulation. They may be a bit research heavy, but they still are a start. And we can actually expand that as we go along, because we always say, once you start, you can only get better. Yes.
So when did we lose the ball then? Maybe that aspect of the council actually having a huge say in the curriculum.
So unfortunately, I think in 2018 there was a lot of illegal contention. Quite honestly, it was a very political thing. It did not serve any purpose that was looking at strengthening regulation. The medical schools were complaining that they feel overregulated. And that they have to, you have to be inspected by Q, then you have to be inspected by KMPDC, and then the nursing council is going to come and inspect you. We're permanently in inspection mode. And I think the Q would simply have to see, how do we align all these inspections to happen at the same time? Not to take away, but we understand some political frustrations that had gone on that pushed some of this decision making. But this is something that even when the union met with the president, if you remember during the prolonged strike, this is one of the things I put on the table, and they said, who is this who took this away? And we said, well, it's taken away. So where we are, let's focus on how do we get it back. Because it is important. And as we say this, it didn't even, because it was not just for doctors. It was for all regulatory authorities. And that is engineering, law, everything. But the lawyers refuse to give it up. If they don't inspect your law school, they're never registering your students. So we do have, KMPDC, I think, is just a typical doctors organization. We are very polite. We don't go to war. We don't fight for these things. But at the end of the day, we are the ones who are struggling because our profession is beginning to be compromised by the quality of training that we are beginning to see. Yeah.
All right. I think one thing that has stood out for me is your statement that ignorance is no defense. Because many a times as young doctors, especially during the periods of strike, you find people throw their requests to all the organizations without that clear knowing that this is KMA. KMA does 1, 2, 3. KMPDU does 1, 2, 3. And KMPDC does 1, 2, 3. So maybe could you, just for our listeners and those ones who are not familiar with the Kenyan health system framework, could you at least highlight what each of them do, so that at least our listeners don't have the benefit of saying they didn't know?
Right. I think that's a really nice question. Because when you have been in the profession for a while, you take it for granted. That everybody, it's so obvious, and though sometimes when I see people asking questions, I'm like, but you're asking the wrong entity. So yes, I'll start with KMPDU. KMPDU is a doctors' union, and it actually falls under the Labor Act, that every professional group is entitled to actually forming a union that will champion for their labor rights. So where it comes to engagement between a professional and their employer, this is where the union comes in. So as a professional, what is important to you? There is your salary. There is your work environment, and there is things like professional development that your employer has some responsibility towards. And those are now the things that the union can champion for. And if you have seen, they'll always focus on improved salaries. They will always focus on hospitals need to be better, work hours need to be better, numbers of employed doctors need to be better, so that we are not overworking the ones who are on duty. And then talking about sponsorship to school, all those are the things that they will champion for, because within the labor engagement, this is where this falls, and this is primarily the work of the union. Now we come to the professional association. The professional association is a voluntary entity where you actually choose to associate with your colleagues in the profession for like-mindedness. So they focus on championing for welfare, for the well-being of the person who has ascribed to this profession. And so it comes, and they do, because they are coming together as the entity that represents the professional contribution of a certain group of people. It does give them the authority to become advisory to the ministry with regard to policy that works around the profession. So this is why you'll find KMA and all the other specialty associations under them will always be called upon. Ideally, they are a permanent stakeholder. And you can actually see how KMA then ends up representing that entity of the profession in certain areas, whether we are talking about healthcare financing now at SHIF, whether we are talking about regulation, they have a seat at the table, and regulation, irrespective of whether it is the professional or things like the pharmacy, because we've always had a KMA seat in all of these boards. And it is important because the kind of policies that are passed are going to have to be implemented by the people who are professionals, and they need to have their input from the outset to ensure that the implementation makes sense. So this is the role of the professional societies. They can be formed as many as they are, because under KMA, our umbrella mother organization, we all belong to KMA as doctors. Underneath that, then I am a member of a gynecological professional society right now, and under that there are still subspecialists that would stem out of that. And these are never going to stop, because as we continue to subspecialize in medicine and have more and more subspecialties, you will find that these entities not only bring the doctors in country together, but also now give them a platform to engage across the globe with like-minded entities. Then we come to the regulator, and the regulator's job right now is twofold, because they're regulating the health professionals, but they're also regulating the institutions. Initially, this was a delegated function from the Ministry of Health, but currently, as per the law, it actually stands as an independent regulatory function of KMPDC as it is. So what does regulation of the profession means? Essentially, KMPDC's job is to declare that as a doctor, you are safe to practice in this country. You are safe to touch patients in this country. Now, for that to happen, it is not just because you have a degree. There is a whole lot more, because we don't know who gave you your degree. We do not know how authentic it is. We have to go beyond that, certify that, do we trust this degree? Can you demonstrate that it taught you enough to make you a safe practitioner to touch Kenyans? And if you have any other additional qualifications, do we also recognize that? So that is the role of KMPDC with regard to the doctor as a practitioner. How this practitioner, who has been declared safe to touch Kenyans, engages with the employer is not KMPDC work. So we have to remember that. And so when we talk about the hospital regulation, now it is the job of, is this a safe institution? And as you can see, despite the fact that KMPDC will regulate it, it will always fall back to getting supportive advisory from other regulators. Because when you want to talk about the nursing care, you're going to look at the nursing profession. So there has been, of course, the suggestion of wanting to have a quality of care authority that is standalone. I will reserve my opinions about that for now. But essentially where we sit, the work that KMPDC does isn't going to be any different. It has probably just been limited by resourcing. Okay. But as we look at it, this is now how you separate the three entities. So if you're fighting with your employer, you go and tell your union. But if your employer has created an environment that it's not safe for you to see patients, then you have a right to actually approach the regulator and say, come and inspect this hospital, because I work here and I'm not feeling like it's a safe institution for my patients. We don't do that. But truthfully, that's why we said every doctor needs to be an inborn advocate. Because there's no way you're sitting in an environment where it's a death trap for your patients, but you can't say anything, or you won't do anything, or you will just leave and somebody else will replace you and continue killing Mananchi where you sit. So that is maybe a very brief way to say we can separate the different roles of the different entities.
Yes, thank you for that. The health front is also a learning space. So I hope today now the 3 roles have been demystified, and now you're much wiser in where you place your concerns when you have an issue with how the practice is being governed. Yes.
Yeah, and still on the subject of advocacy, I think for most people, especially particularly for the doctors who are on the ground and who see the patients every day, advocacy is like this big thing that we've reserved for people who are in Nairobi, in
contact with them,
in KMA, they're KMA officials, like those are the people who are supposed to do advocacy, us we're supposed to treat. So what do you tell them? Like, what strategies can they use? Like, how do they start now stepping into that position of an advocate, even where they are?
Very basic. Always very basic. Always put your patient first. And they always say, imagine yourself as the patient. Do you think that this is the best possible your patient can truly have? And especially with regard to the resources that we have. So for me, one of the biggest challenges I feel we have in healthcare is that for the longest time, healthcare has been under-resourced. And we have all known that. However, we've reached a point where it has become our excuse to do nothing better. So what you find is that you come to work, you go to theater, it's your theater day, and then you find there is no oxygen. So you just sit around for 2 hours and say there was no oxygen, and then you go home. What happens in theater? Who's the team leader? It's always the surgeon. So as the surgeon, if you do not come out and say, this is my theater day, these are my patients, I need to work one way or the other, and it's not my problem where you're getting this oxygen, but I am here today and we shall operate. We must make people uncomfortable so that they deliver on their end, and we keep forgetting just how important we are in making that happen. That for me is a pain point. Okay? And it's not big things. It is the small things. I worked in Mutonyi Maternity Hospital 2 years as a medical officer. And I always tell people that was my best work experience. I loved it. And when I was going there, everyone told me, oh my God, you're not going to survive in Mutonyi. You know, it is so wild. It's so crazy. The patients are so many. I said, okay, what I've just heard is it's a challenge. And I'm always up for a challenge. So I stepped in and I was like, I love this place. I love this unit because I may be ADHD, but I am very happy to be focused on one area. I am not the kind of person who can work in an A&D. The 1 minute I'm dealing with burns, and then the one's having an asthmatic attack, and this one fell off a building. My brain does not function like that. But I like the emergency of labor ward and the unpredictability that anything can go south any minute. But it's all about obstetrics. So I was very, very content in that space. But there are a few things I never used to understand. Now, I remember the first day I came and I was being taken for orientation. My senior who was orienting me, somebody who was also my senior in medical school, so I knew her well. And we did a C-section with her. And then, so I was basically just assisting. Then we finished, and then we went and sat. She wrote her notes, and then went for a cup of tea, and then she asked me, so what do you think we do different that you'll need to adjust to? I just looked at her, and then I said, I just want to know where you learned how to do a midline incision that ugly. And she said, what? I said, yeah, I know where you trained. I know where you interned. They don't do those kinds of incisions on women. Why would we give them such ugly scars in this institution? And then she said, oh, but in this place, they don't even give you the right sutures. So we found it being done like that, and we just continued. And I said, did you ever ask? And she said, she looked at me like truly she had never thought about it. You know? And that's where I started. And for me, I remember I said, I am never making that ugly incision. If the patient already has the ugly one, we have no choice. We'll work with that. But for a person who's coming for a C-section for the first time, not on my watch. And so I started going to the medical superintendent. In fact, I did my research and I came with all the price ranges. I told him, whether you bring me a nylon stitch or you bring me a Vicryl stitch, they all cost the same. I don't know who your supplier is. I don't care. But I just want the supplier to know that he's going to have to start supplying something that I can work with. And before we knew it, it had become a norm. And now the other medical officers who this is what they had learned, we all quietly adjusted back to what was known. We were done with those, and it was not something that required a war. You just realize that sometimes when people have been in the same space for so long, they stop thinking about how to make things better. Why? Because we are not trained in management. So we are not trained in how never to be comfortable with what you already have. We always assume the hospital belongs to the government. I am just passing by. I am just a glorified employee. I'll come do my 1 year, 2 year, 3 years, and I will leave. We don't look at it as, when I leave, how do I leave this place better? You know? And if each one of us would pick one item and say, this one I am running with. We are 10 in the room. Those are 10 items. They are things we can achieve. So advocacy is everywhere. There is no such thing as it's at the top with big decisions and all of that. Even when the big decisions are made, they need to be implemented. The implementer is down at the grassroots level. And for that to still be implemented, it still requires advocacy. So we have to be willing, really have to be willing. When a doctor goes out of their way to give a CME and say, now our hospital has brought in CPAP machines, this is how we're using them and we're training our people, that's advocacy. We don't think about it like that, but that's your moment to make it shine. I always say, you do not want to start 50-50 and hope to improve as you go ahead. You want to set the bar so high at the beginning whenever you have the opportunity. Because if you start with a very raised bar, then people don't know it can be any less. They only know it can be only that way. And it can only improve, never coming down. So we always get to have that opportunity, especially as doctors, because we are the ones who are looked at to always make sure that these things are implemented. If we can just insist they start right, then that's advocacy. We don't need to do anything else.
So essentially, we can't be comfortable with problems.
No. Irrespective of the resources we have, we cannot be comfortable with problems.
I love that. And I know over the years you've been in various spaces where you're doing the same thing, which is advocacy. So I know it hasn't been easy. So what challenges have you faced, and how have you overcome them to actually get to the place that we need to be?
I think for the longest time, advocacy was always focused at the high level decision makers. So we forgot to empower the little people who actually have a humongous sway on the decision makers too. So I felt like sometimes when you'd come to talk to colleagues and tell them, guess what, we can actually push for this to be better. They don't look at you like it's somebody else's problem. And just the being able to really draw out doctors and say, it's not somebody else's problem, you are the somebody. That was a lot of work. But I'm so excited that we're actually seeing a huge turnaround. I remember a few years ago, we could count the number of doctors who would willingly go on TV and speak, because everybody was camera shy. Oh my God, TV was reserved for certain people. And it was just not funny, because I spent all my, life going from one TV station to the other. And I am like, I have colleagues who, some of them even are better, they're better knowledgeable about the topic than I am. I want to see more doctors on these TV stations. And now they're all over the place. And I am excited, because I'm like, wow, now they're talking. Now they're doing what they should have been doing from 20 years ago. But it's never too late. Here we are. For me, I'm really, really proud. Every time I look on TV and I see someone I've never seen on TV before, I'm like, yes, something gave, and those are successes. With regard to advocating to government, my biggest challenge has always been the politics of the fact that there's always change of office with every new election. So you start a pathway. You do very well with the sitting offices right now. Whoever is in political office for this duration, you lay out your path, you're sure about how you want things to go, you work it out from the beginning to the end, we begin to invest in that. And then boom, we go into elections, every office holder is changed, you're back to square one. And the worst part becomes that square one, every time you try to bring the same agenda, they look at you like you're asking us to implement the agenda of the guy we just removed, not our interest. So it's really mind-boggling how we waste so much of resources, because every new government comes in and wants to start its new thing, yet it does not have sufficient time to complete it. You know, somebody else already built the hospital. Your focus should be on operationalizing.
Yes.
You know, and if you operationalize, then we're going to say, we want this to be the center of excellence for ABC. How do we ensure this dream is not lost, even after you are gone from office? So we that for me is a big challenge in this country. I do not know how we're going to come around that. We have governors who have started building hospitals that are still in shells, but the incoming ones have gone and started building their own. There has to be a law against that.
Yeah.
I mean, seriously, those are public resources for the community you serve, not for you as the governor. I believe there should be a law that tells them you cannot start a new project until you complete the one that was already there. And that way, then we are forced to hold to account the outgoing officers if they wasted money, because it's not going to move until you do what? You pay off what your debts were. It becomes a space where we discipline them and we hold them to account, so that they're not just sitting there eating money and waiting for, oh, when my turn is over, I can leave and nobody's going to ask me. I've left you your problems, you can deal with. That for me is a big one. And I believe even at the national level and the international NGOs that work in this space, that has been something that we all observe has been a problem. So how do we go about it? I think there is that need to advocate for certain laws to be enacted to protect public resources from wastage. But overall, I think also what I always say is that even when the politicians change, the technical people remain the same. We are the doctors. This is our profession. When we talk about the departments of health at county level, the Ministry of Health at national level, we are the reason it exists. So we must really take up our responsibility. What we have done is to sit aside and make it look like it's always going to be somebody else's problem. We're never going to make progress that way.
And I grew up reading Dr. Dawood on the Sunday Nation. My dad is an avid reader. Every Sunday he would make sure he gives me the article personally.
Read this one.
So I grew up reading Dr. Dawood. And I saw you also now took over the same article. And I just tell us more about that. Like, how did you end up being a writer in addition to doing all these other things?
Like we said, today we have a stellar guest with us. So many hats.
I must say that, yes, just like you, I am smitten by the word. I was very young when I started reading. And at the same time, when he wrote, there was also the magazine that was the Reader's Digest. And it used to have the most amazing medical stories. I, interestingly, was going to become an electrical engineer. So I don't know what I was doing with that interest. But I avidly read the Reader's Digest. I avidly read the Word. I never imagined myself as a writer. I mean, I wrote a lot. In fact, I laugh and I keep saying I've kept a stack of all my journals. I hope to pass them on to my grandchildren so they can laugh. But I always wrote. I never imagined I would write for print, but I remember when the Nation was launching what they called the Healthy Nation pullout. They were actually looking for technical people to write. And one of the editors was a friend, and he told me, do you think you'd be interested in actually doing something? I said, oh, wow. I was very excited to jump at the opportunity. I was like, yes, I have so many things to say. And, you know, I was in the advocacy space. I was like, I know I have so much to talk about. And I just didn't know how hard it is to write every week. There is no room for writer's block. Let me tell you, I have great admiration for that man. Now, listen to this. Remember, Dawood started writing when there was no computer.
Exactly. He was
literally writing.
Thank you. He typed out all his articles on the little typewriter. I know you guys, I've never seen a typewriter either. But it's okay. It's okay.
In the beginning,
you know,
there was a typewriter.
There was a typewriter.
Before
and you used to type, and you go to the end of the page, you'd have to push a lever, and it goes all the way back to start the page. And he used to do this every week. And remember, Dawood's family lived in the UK. So when he needed to travel, he had to have done like 6-7 articles that he would then leave in stock. So imagine him on his typewriter after he has had a long day in surgery, then coming home in the evening and having to type all these stories and then leave them with the editor. And then came the computer and was like, oh my God, life is so much easier. Now I can put it in a diskette. Do you people know what a diskette is?
The floppy disk.
Yeah, yes. Oh, you actually know that?
Yes.
Are you sure? I thought you were too young. You were taught in theory.
Something called a floppy
floppy
disk.
disk.
Some of us actually used floppy disks. And so he did the floppy disks. And so now every Friday, he had to have the floppy disk delivered to the nation. Remember, everything had to be delivered in person because, or you had sent someone. Because there was no, I can email you, and remember Telegram. People don't even know what that is. Well, a few words. So you could never telegram a whole article. And anyway, by the time you go to the post office to send the telegram, you might as well have reached nation and handed it in. So it was quite a journey to see. It's not just that he consistently wrote for all these years. That man wrote for 60 years. 60. I have just written for about 6. And I'm just thinking, wow. He wrote for 60. And he always submitted his articles on time. That one, he challenges me because I feel so terrible how often I'm pushing the deadline every time I have to submit an article. But yes, I took the opportunity, and I honestly must say I'm grateful to the nation for the platform because it has allowed me to express myself from end to end. I can talk about medicine from a clinical perspective. I can talk about medicine from a community perspective. And I can talk about medicine from a policy perspective, and all of it in an effort towards, advocacy, education, and empowerment. And we hope that as more people understand how healthcare runs, then they are able to demand better when it comes to saying, you want my vote, you need to show me what you're going to give me with regard to health. They would never have been able to do that if they don't have enough information.
All right. Fantastic.
There are a few changes happening right now. I think we've seen all these videos of women in hospital saying they said we come that we've paid for SHA, so we should actually be allowed to leave the hospital with your baby. Immediately you deliver. But that's not the case.
Absolutely.
And where I work, I work in primarily the medical ward, but once in a while I also help out.
Yes,
and I saw mothers who are coming postpartum, like 2-3 days post delivery, and they delivered at home. So I'm wondering, and they're young people, like you expect, they're educated, they know these things. They should know actually you're supposed to go to hospital, but they're like, I'm not sure about the financing aspect, who is going to pay the bill. By the time they're coming, the baby has sepsis.
I know.
And in some cases, even the mom herself has sepsis. Yeah. So what's your take on that?
What can we do better for our mothers?
There's a lot. And I will start from a very controversial perspective. I have never been a fan of affirmative action because I always feel like it grossly disempowers the person it's aiming to empower in the first place. Because if you look at beneficiaries of affirmative action, for the longest time, it starts out really well, and then after a while, people become entitled. So we lose the concept of why we had affirmative action in the first place. But that said, every country has to have a plan for emergency care.
Yes.
End of story. And emergency care can be anything, whether it's a road traffic accident, or whether it's a pandemic, or whether it is a baby being born. However, when we introduced free maternity care in the NHIF space, what we called Linda Mama, we sort of, remember, the women didn't need to pay anything. They just needed to sign up. Okay? But those who had NHIF, they reimbursed, those ones who had signed on to NHIF as subscriber, their reimbursement to the hospital was higher. So in a private setting, that would make sense, because then you can say once the basic care has been met, the one whose reimbursement is higher can have additional, I call it hotel facility. Simple as that. You can improve your room, or instead of sharing a ward, you can be in a private room, those kinds of things. But in terms of, was the baby delivered safely? Was a cesarean section carried out as per minimum requirements? That one, everybody has to have a right to access the same equitable care for all. Now, The unfortunate bit is that in the public sector, you couldn't even tell the difference. Okay? Then comes SHIF that says, no, you just need to register. This is a primary care service. It is funded by, but people don't realize it's exactly the same thing that Linda Mama did.
Yes.
Unfortunately, and this is where I keep saying, are we breaking the law without realizing it? Is because if it is a primary care function, then all the patient needs to do is to be registered.
Okay.
Remember, most people don't seem to understand the role of, everyone uniformly calls it the Social Health Authority.
Yes.
But the Social Health Authority's oversight is over 3 different acts.
Yes.
It is overseeing the Primary Healthcare Act.
Yes.
It is overseeing the Emergency and Chronic Disease Act.
Yes.
And it is overseeing the Social Health Insurance Fund.
Okay.
Okay?
Yes.
Now, primary healthcare does not require anyone to pay because it's a tax-funded program.
Yes.
So the exchequer is supposed to actually allocate money to take care of 90% of our deliveries.
Yes.
It is only the complicated ones that make it to level 5 and 6 where we should then be invoking SHIF. And if this patient is in the hospital beyond 2 weeks, we should be invoking back to the taxpayer at the Chronic Disease Fund.
Okay.
Are we getting?
Yes.
For me, that is how I understand the act. I am sorry if anybody else is implementing them differently, but when they wrote the act, this is how we envisioned it, and this is actually what it spells out. Now, it spells out what these funds should do, but what we are seeing is that we are not adhering to what service falls within PHC, what service falls to SHIF, and what service falls to Emergency and Chronic Disease Fund. So if I have a miscarriage outside Nairobi Hospital, I don't care about maternity, it's an emergency. And the emergency fund should reimburse Nairobi Hospital as such.
Yes.
If I am coming to antenatal clinic and I go into labor and I check into my level 3A hospital and I deliver there, I am still under the primary healthcare fund. So the hospital must be reimbursed, and the only thing that is required of me is to be registered, not paid, registered.
Okay.
What we are paying, all this means testing your hearing, is for SHIF.
Yes.
It is not for primary healthcare.
Yes.
So to hold these women who came from primary care services is illegal. And I understand the hospitals because the Social Health Authority is refusing to give a guarantee that it will pay for this service.
Yes.
And that is the reason why they're like, the only bargaining chip I have is to hold on to this mother so that they can release money. The challenge is we have refused to understand the separation, and the hospitals are not being reimbursed. So this is their bargaining chip to ensure they get some money back, because they have already spent so much of resources. They need to have money to reimburse for the next incoming lot. Okay? But I come back to one thing. You know, if you are walking today crossing Uhuru Highway and you got run over by a truck, you didn't plan for that. Okay? And surely, this is where our emergency funding should come in. But we're pregnant for 9 months. Okay? I understand adolescents and young people. But I have a struggle that we are a country where we don't plan for the children we want to bear. Because quite frankly, if you cannot demonstrate supporting the care of your baby through antenatal and delivery, then you cannot assure me that you will feed this child and make sure they get an education. So I come back to affirmative action. I want all women to walk into hospital, and I want all women to deliver safely. Okay? But I also want us to start a culture where we help the women to start preparing for these babies they are going to have. So we come back to, you're pregnant for 9 months. Is there a way to say, come to clinic and let us figure out together, how do we contribute throughout the pregnancy towards something? So that when the baby finally comes, we're ready. Because what did the mothers do before? They saved. Now we're telling them, instead of keeping it in your pocket, please do what? Put it in some little fund here. And so I come back to government that no, you cannot insist on an annual premium. give us an opportunity for a monthly premium. So that even if the father of this child works in Isiolo and the mother is in Bosire, they can both contribute to that same fund on M-Pesa without having to have a conversation about it. And even if we make moms in the village contribute as little as 50 shillings a week, please, for 40 weeks, they have more than paid their premiums. Are we understanding? But then when we come and make these random political statements of everything is free, nothing is free. These women's taxes are the ones that are still going to do what? To pay for this maternity care. But we are disempowering her when we keep running this free notion. What we're saying is, let's partner and say, people, let's make it safe. How can we make it better? If you give me 100 shillings every month, when you deliver, you're going to sleep in a private room. I know we don't have those, but you get what I mean. Because it will also motivate us to now start creating those. You who totally cannot, and we will pay for you because we are paying for indigents. First of all, can it be paid in time? So that when this indigent woman comes to the hospital, you're not starting to tell her yada. She knows I will come, I will deliver safely. I know I will be in a general ward bed where we are 8 of us in a cubicle, and that's fine. But I am safe. My baby is safe. The nurse who cares for me doesn't treat me differently from the patient who is in this private room on the side. But this one who has a little money to, because when we tell them we will pay for delivery 100%, where do they take their money? Have you seen the fancy clothes they buy for their babies and the 17 blankets they'll never use? Are you getting my point? So can we reorganize? Because the resources are not lacking. We have just told them the most important aspect of bringing this child into the world is not your priority. And that is disempowerment. Because then now when they arrive at the hospital and they have no money to pay for these things, what happens?
They're stuck.
They're stuck with us. And every hospital keeping them forgets that it is more expensive to keep them and feed them for 2 months than release them home.
And release them.
Exactly. And then figure out. So what we also are stuck with is collection after the fact. Last week, a court declared it unconstitutional to hold a body in matter. I think we all saw that.
Yes.
And what did it say? The hospital should put in place mechanisms to collect. This is now the only part I hold the court to fault. Can you make clear pathways so that because when hospitals realize that every time somebody comes, doesn't pay the bills, they pass on, they'll just run to court and the court will say release the body, what is going to happen is that the private hospitals are going to refuse to admit without money upfront. And they're going to tell you it is not an emergency. And if you insist it's an emergency, they will stabilize you and refer you back to the public health system. And then we will continuously overburden the same public health system we are not funding. So we are going to have to be very clear that you must also work within your means. Don't start out in an institution you cannot afford to pay and then want the court to come in. It is not fair for the business person who has to run the entity. It is not fair for the work people who don't get paid because you didn't pay your bills. It is as simple as let us have clear pathways. Allow hospitals to say, look, if your bill gets here, you need to clear it so that we are plowing that money back into your care. Even if we're continuously paying every 3-4 days. And then where the money runs out, you need to tell us what is your long-term plan, because the patient might still be stuck here. That way, you can hold hospitals to account for refusing to release leaving patients to go and access the service in a place they can afford. So what is the role of Shifsha if all of us are onboarded? The reimbursements that it gives should in the very least cater for this care in the public sector. So that in the private sector, we can top up. And know that I paid for hotel. I did not pay for the care. I paid for hotel. Okay? I paid to personalize my doctor. Not any doctor on duty, for instance. I can pay to personalize my physiotherapist. Me, I only like that one. So I can pay extra to make sure that even when she's not on duty, she'll come to attend to me. And that's fine. But the rest of the manner in which we are structuring this, I feel like it's not helping. It is completely dehumanizing the same people it is thinking it is here to support. And we cannot have a nation where we have raised people to think their job is to sit back, do nothing, and wait for government to come in and do for them everything.
You can't go anywhere.
It is not going to work. There's no economy in this country that can support that kind of attitude. So we must rethink healthcare and always tell people, there's nothing in this country, there's nothing in this world more expensive than healthcare. You can never buy health. You can buy treatment, but you can't buy health.
Okay.
And treatment is expensive.
Yes.
As Kenya, we have been fooled. We are normally shown the price of care. We are not shown the cost of care. So when you look at even our shift tariffs, they have been calculated based on price. They've not been calculated based on cost.
Yeah.
And when they'll be calculated based on cost, we shall know that it is not enough.
It's not enough. Yeah.
It is not enough that we expect 10% of the population to contribute for 90 because we have refused to put mechanisms in place that ensure that the 90 are also contributing.
Yeah.
Yes.
So I have a lot of faith in SHIFT being able to work. I fault the funding mechanism. For me, that doesn't work. I'm sorry. But we need to look at it differently and be able to say we need a better model. And accepting that we need a better model does not belittle the people who had a bigger picture of what SHIFT should look like. It's just that, look, if you put something in place and it works, then the next thing I think about is how do we make it better? When Thika Road was being done, we were like, what is this investment? Do we even need this? It is here today. We are proud of it, but it's not enough. Now we have the expressway. It's not enough. We still want to continue expanding our roads. And every time they come to work, we realize what we didn't have and how much better it works. What we're struggling with is an attitude of the inventors thinking that we got it right and you have nothing to tell us. And if we can just change that attitude, I believe we can do a lot. But we also must come back to our people. Because we must own when you want to travel, you will pay for bus fare, whether fuel is 150 shillings or it is 190 shillings. They will tell you fuel has gone up, you will pay. Why don't we employ, because the person won't stop traveling because you said fuel has gone up. They'll be annoyed, but they will figure it out. But the same thing in healthcare, like we need to say, look, this isn't working and we need to reconfigure. But you must have people own the process, believe in the process, and be able to directly link their contribution to the output, to the benefit that they get. Okay? To be able to say, look, even if I have never claimed for 6 years, the fact that my mom has been getting treatment means that what I contribute is also getting to her. And we haven't created that. We started from a point of resistance. We haven't done much in advocacy to improve. Because right now, all you ever hear whenever you go to public barazas, anytime a government official speaks, all they say is, and you must enroll in SHIFT. It's like it's mandatory, it is forced, there is no one who sits down and says, people, this is our situation. This is our county, this is our challenges. At county level, this is what we have. This is what we can provide. If all of you are able to enroll, can you imagine this is the kind of support we will get? This is the amount of money we can generate. And that is here at Health Center XYZ, the one that has not had a doctor, we can put a doctor. At Health Center ABC, where we have so many babies coming from that side of the community, we can be able to say we need a neonatologist. And when people begin to appreciate how what you're contributing feeds into this kitty and benefits you this way, you won't need to force them.
That's true.
They will wake up. And so we didn't get that. It was a bulldozer approach, and obviously Kenyans are Kenyans. The moment you try to force us, we were born to rebel.
Yes.
We shall rebel even when it is for our own good. Absolutely. So we want buy-in. I believe this country has enough people who can do that. But you cannot make people buy into what they cannot see.
Yes.
Cost versus benefit. We must see clear benefit, and then we can build on that.
All right. So we've discussed quite a bit, and I think one of the key, I'll bring up a trending topic, both Kenya and Rwanda. So in Kenya, we had our CS saying our teenagers will get free maternity care. Whereas when you look across the border in Rwanda, they've reduced the age of access to contraceptives and consent. So I don't know, as an obstetrician gynecologist and director of Thriving Teens, do you think Kenya is doing right by our adolescents with the measures we have in place, or not yet?
Kenya is an interesting country. Okay.
Should be studied.
It should be studied. because we make very emotional decisions. We hardly ever focus on factual, data-driven evidence to make decisions when it comes to adolescents. They are the most punished and the most neglected group of patients, if you would, or of citizens in access to healthcare. And for the longest time, in Thriving Teens, one of the things we focus on are adolescents who are living with chronic diseases and looking at their transition in care. So you have a child who had rheumatic heart disease at 6 and has been in cardiology care until she gets to 13. We don't have an adolescent clinic. We kick them into adults. So they've come from this clinic where they all hang out, they know each other, they're children, then all of a sudden they have to sit on a bench with old men who are, this guy has had failure, he's 67 years old, he's on a wheelchair, he looks scary. And then you expect the 13-year-old to sit there and that's the same clinic they're attending. So we have no room for adolescents. We've never thought about them as independent units.
That's true.
We actually don't have adolescent hospitals. We do not have adolescent clinics. When we talk adolescent clinics, it only goes to reproductive healthcare. We forget that an adolescent is a whole human being. So how are we packaging? I mean, we've had so many lessons learned from the execution of HIV care. Why can't we adopt those models to work everywhere else? That when you run a cardiac clinic for adolescents, that they can get their cardiology care, they can get their reproductive health care in the same space, they can get psychotherapy, so that it's a one unit, a one-stop shop. You come in, you're seen here. If I think you need therapy, you cross the room, you are ready for your first gynecological visit. We're disseminating information in the same space. We need to change how we look at adolescents. The issue of consent is big. And I like the Rwanda approach. That one I have no apologies to make. We need to actually accept that our adolescents are in transition. They are in the gray area. Okay? And in the gray area, they still need parental consent for many things. But there are many things they are going to do irrespective of parental consent. I want to meet a parent today who will tell me that their 16-year-old will tell them, Mom, today I want to go and have sex with so-and-so, and they will say yes. They are obviously going to say no. But the adolescent is going to go ahead and do what? And have sex anyway. So when you're saying that this adolescent who knows that they cannot seek consent, but knows that they should keep themselves safe, is denied an opportunity to access services that will, because sometimes I see adolescents who come to see me and I tell them, okay, so you think you're ready for sex. Great. So let's go through it. Tell me, how ready are you? Where are you going to have sex? Who are you going to have sex with? At what time? Who is paying for the room? Show me the contraceptive, okay? And show me the plan in case it fails and we get pregnant. So how will you handle that? And they will look at you and say, oh yeah, okay, I'm not ready. I'm not ready. Let me go and rethink this, And we do not have to make them look like they're so stupid they can't reason. Let's sit down with them and reason with them. Because that way we are empowering them towards decision making and towards shared consent. Because once we actually create space for our adolescents, and one of the people we have to talk to is parents. You cannot parent your adolescent living today the way you were parented. Gen Zs have shown you stars. Wait till you meet the Gen Alphas. They will fire by you. You will not believe it. So if you think that you're going to parent them the way your parents parented you as a parent, you are going to be on the losing end. So Rwanda's space is progressive in one way, but I want to see parents stepping up and saying, if my child is going to be able to take this decision without my involvement, I must make myself useful. I must join into this process of decision making, because if I don't, it will pass by me and I will not say anything else. So it's actually a challenge to the parents, because at this point they're very comfortable. They just know that I'll never say yes, so I don't have to deal with the reality that my child could be having sex. But the moment they know that they could be having sex and they don't need your consent to go and get a contraceptive, they will wake up. So it is a plus. For me, that is the plus. And I see it that way, whichever way everyone else would want to choose different.
All right. Great. Thank you for those amazing insights, Dr. Bosire. This has been the Health Front by the Kenya Medical Association Young Doctors Network. Probably to wrap up, is there any other parting shot that you have for us, Daktari, as we wrap up the podcast this afternoon?
I just want to tell doctors one thing. The manner in which medicine is trained is like the military. It breaks you to make you. And what does this do? It means that a lot of children who are very creative and very forward thinking and very innovative as children, it's literally beaten out of them for 6 years in medical school because they are forced to only conform to a certain line, to this one tiny box. So we have to accept that our system, our teaching system, has a long way to go to fit into training the doctor of today. Okay, so we must take it upon ourselves. Where you're sitting as a student, as a young doctor, rediscover your curiosity, rediscover your need to innovate. Think outside the box, because you're the ones who are creating the future you're going to live in, which means you're going to determine how healthcare runs then. We will not be the ones making decisions. We will not be the ones working in that environment. You will. You get to decide what kind of environment you want it to look like. So don't sit back waiting to be employed, waiting for somebody to take pity on you and give you a job, even without pay. Innovate, because the greatest innovations in the world, especially in healthcare, the innovators were not looking for money when they invented them. But once they did, then they got rich out of their innovations. So think outside the box. Do not be confined. Do not lose your other talents because you went into medicine. I always tell young people, you're smart enough to be a doctor. I promise you're smart enough to be anything. So don't sit here and just say, because I have a degree in medicine, I can only do a degree, master's, waiting for masters. Can you do all the other things? I'm very proud of some of the young medical students I mentor. They've actually already understood that. They're already doing short courses online alongside their medicine. When we used to graduate, our CV used to have 1 degree. Now their CV has 1 degree and 15 certificates in the 6 years. We don't have to wait. We don't have the time to wait, actually. Not anymore, to be catching up with the rest of the society. So any other course you can do alongside being in medical school, I promise you're smart enough to do it and pass. And you have the privilege of being able to do it online, in your room, without leaving. Don't waste the opportunity. We didn't have it. You have it. Don't be our age to achieve what you have achieved. We want you to achieve what we have achieved when you are 20 years younger than we were at this time.
Yeah, and with that, we end there.
Yes.
Thank you so much, Dr. Bosire.
Yes. So next steps, how to be a Kenya Medical Association member. Head down to kma.or.ke and register to be a Kenya Medical Association member. By being a member, especially as a young doctor or a medical student, you're automatically co-opted into the Young Doctors Network, where we have such conversations and other more opportunities. So from our end, we'd like to say thank you to Dr. Bosire for being our guest. Until the next conversation.
Thank you.
Keep it KMA Health Front. Bye-bye.
Bye.